It's a pleasure to be here. It's a pleasure to introduce you. I'm Elise Ames, for those of you that don't know me. I'm the Program Director of Orthopedics. It's a pleasure for me to introduce Valerie Lewis to you. Dr. Lewis is from MD Anderson in Texas. She is a orthopedic oncologist with a specialty in sarcoma and pelvis reconstruction, as we learned yesterday, as our residents spent some time with her. That being said, she is not a stranger to the East Coast. She's actually a New Yorker to start with, did her residency training at Yale, and then her medical school training at Yale, and her residency with Henry Mencken, who is the father of orthopedic oncology at Harvard. And clearly, he established a passion in Val, for sure, in terms of what she was interested in. And she pursued that by finishing her musculoskeletal onc fellowship with a gentleman named Mike Simon in Chicago, who is, as much as her first mentor was involved in musculoskeletal oncology, Dr. Simon is also involved in musculoskeletal oncology and orthopedic education. So clearly we have multiple passions here that we saw yesterday as she worked with our residents. From a CV perspective, this is a chair at MD Anderson who is pretty darn impressive. I believe, over $5 million in active grants as a primary investigator right now, and those grants are both in basic science and in clinical care. She runs a department that is not only orthopedic centric, but also works within teams in the hospital. We had some great conversations yesterday about how that relates to all of us and how that relates to her expertise. She is a mom to 2 college-age athletes, so she has a lot of identity with all of the things that we deal with every single day. And more importantly, she has a systems focus in what she does. And it's super interesting. You might think that MD Anderson in Texas and the University of Vermont might be very different. And in some ways, they're very much the same. I suspect that will inform her talk with us today. And then last but not least, as you go through that CV, you'll see 158 PMIDs. I'm like, good Lord, does she sleep? I'm not sure that she does. What she is mostly interested is very much informed both her work as a musculoskeletal oncologist and a chair and leader, but also as a educator, and it's caring, it's compassion, and it's opportunity for all. And that is a major focus that you'll see in her literature that she writes, in the talks that she does. She is very active in all of our specialty societies at this point. And I suspect that all of that passion, all of that interest, all of that little bit of dogged determination that systems need to work and work well, that is right central to her MO and her DNA as I read it. I suspect those are going to come forward in our talk today, which she calls our path forward. So we're going to hear what that is.
Thank you very much, Elise, Dr. Ames, and Dr. Nichols for inviting me down. It's awesome. My daughter goes to Middlebury, so she plays soccer. I'm here every weekend in the fall, and then I don't come after November. She's like, "Are you coming?" That'd be no. But so it's great to actually come up to Vermont in in the winter. I still very much love snow. It's funny because yesterday you said I had like a passion about diversity. And so I started thinking about it like, do I have a passion about diversity, or am I a Black woman? So by default, I have to have a passion about diversity. Because, growing up, in the 80s, Party of Five was totally my show. You probably were all too young for that, but Friends was big. And I was always wondering, my father never watched those TV shows. I mean, partly because they were completely insipid, but I think the other thing is he was tired of watching things that did not look like him. So one of the things that has kind of pushed me more towards diversity and inclusion is with 2 young girls coming up. I want them to look out into a world or to profession that really looks like them. And I do love orthopedic surgery. I love being in the operating room. I love the patients we choose. But I think the kind of outlook or what orthopedic looks like, really, it's time for it to change. So I thought we'd talk about our path forward. So I think in high school, I thought this was going to be my path, clear and straight, leading me through the course and kind of, reaching where I wanted to be. You know, I love this quote by Isaac Newton. I've seen further than others. It's by standing on the shoulders of those before me. And these are kind of my mentors and sponsors. In the upper left-hand corner is my dad. And that's actually my dad graduating from medical school with my mom, his parents, my mom's parents. This is actually Dr. Mencken, who's the father of orthopedic oncology. Dr. Sim, who's probably the best pelvic surgeon in the world. Dr. Springfield, orthopedic oncologist, and we joke that his hobby was writing me recommendations. He's still an incredible factor in my life. Judah Folkman from Texas Children, he was the father of angiogenesis. He was an incredible mentor. I wrote my thesis in medical school in his lab. Ramon Jimenez was very interesting. I did the LFP program through the academy, and now they kind of have a leadership institute. So I really encourage the residents, junior attendings to look at the Leadership Institute, both in the academy and in the AOA. But Ramon was my faculty mentor, and he was a joint surgeon in California. And then Randy Weber in the lower corner was the chair of head and neck surgery at Anderson when I became chair of orthopedics. And he was always on my speed dial, and he really helped me navigate the issues of being chair. So I feel like I am a great chair really only because I could rely and have the mentorship and sponsorship of these people. I come from New York, diehard New Yorker. I went to Fieldston from pre-kindergarten to 12th grade. I went to Yale undergrad, and then I went to Harvard Medical School. I am a Yale fan at the Yale-Harvard game. And then I did the Harvard Combined Residency Program and University of Chicago for my fellowship. So I was very excited when I entered orthopedics. This was the time we were going to take over the world. But if you Google orthopedics and you hit images, this is what you see. Really just lots of white men. I don't see anyone that looks like myself. In the lower left-hand corner is actually my faculty, which is incredibly diverse. We still need more women, but we have Hispanics and Asians and African Americans. But really, it's not like you bring forth lots of pictures of women. So even though women now compose more than half of the medical school and 32% or 35% of active physicians, they are really scarce in surgery. And they're actually super scarce in orthopedics. According to 2019 data from the AAMC, women make up less than 1/4 of the 10 surgical specialties. So in the US, 5.8 physicians are identified as Hispanic, 5% African American, 3% American Indian, 1% Native Hawaiian, 2% of physicians are Black women, and 0.5% of orthopedic surgeons are Black women. And this is kind of where we stack up orthopedics. And it's surprising that urology has more women than orthopedic surgery, but we're still hanging out for board certified at only 5%. Now, actually, I think the AAOS data may say that we're up to 7%, but at board certified, we're woefully, woefully underrepresented. And we're the most fun of all these specialties. So it kills me. So the question is, why is this the case? And I was young and I did love my residency at Harvard, but it was incredibly chauvinistic. So I thought, well, the old people will die out and then young people will come along who will be enlightened and inclusive. But we all saw, and these are quotes from the orthopedic Google document that residents who are in medical students who are interviewing to be residents put in. And these are the clean quotes. Why ortho, the phrase, excuse my language, fuck bitches, get money comes to mind. And this was kind of what went through the statement. So these are the people that were recruiting to orthopedics. So are we changing the face of orthopedics when they're talking so disparagingly about women and medicine in general? And I think what was most disheartening were not those quotes, because I was residents with them and we're used to those quotes, but the reaction. Nobody was surprised. The quotes are, I can't say I was surprised at all. This is ortho, and they're articulating what the specialty has modeled for them. I wish I could say this is unbelievable, but it's not. We've all heard these stupid asses, excuse my language, carrying on like this forever. Sad. I'm sorry, you have to read this in 2021. And then this was a surgical oncology colleague of mine from Anderson. I saw this and I'm so appalled. I immediately thought to send it to you, though you're already aware. So not only are our attendings not surprised and slightly embarrassed, but the other specialties they were just dumbfounded by this behavior. So is this who we are? But more importantly, is this who we want to be? And no, it's not about the few bad apples, because this is the culture that we've created where they actually feel safe saying these things. And so the question is, why are these the candidates that we're looking for? I do think Danny Guy I'm on the board of the Academy, and Danny was our president last year. He came out actually pretty quickly. We got together as a board and he came out of a response. So we're trying to make it better. But the question is, what else do we need to do? So I'm going to start with this Joe Zuckerman article, and Joe is the chair at NYU, and he has been, or I've been a super fan of his, literally for 15 years. So you remember when? Actually, you guys probably don't remember, but the DoD came down and took all the funding from orthopedics because we weren't being blinded and there was conflict of interest. So they took funding, and Zimmer used to fund the SNMA, and so Zimmer took all their money back. And Joe Zuckerman funded that conference completely from his own wallet. And for that, I just thought he was a superstar. But this is a great article talking about the divergence of diversity over time. So, type 1, diversity was seen as a necessary evil. And I don't know how much you follow thoracic surgery, but at the Thoracic Surgery Society address, the thoracic surgeon last month stand up said the only thing worse than thoracic surgery than the Jews were the blacks. So it's still in other specialties, but that's what medicine is. So really, it's seen as a necessary evil. And then the second is diverse population was recast as nice. So it was kind of like the savior, nice thing to do. The third one, it was recognized as achieving the full potential. So diversity does bring different views of to the table, and it does keep you out of trouble. One of the examples in business is when they made airbags. It was a table of white men coming and they sat around the airbags and they thought it was genius. And it is genius. But then they found out the airbags were killing women and children in the passenger seat. And that's because no one at the table was under 100, 75, 200 pounds, however much big men weigh. And they actually, once they became kind of multi-gender, they were like, well, we need these airbags to either not deploy if someone's under 100 pounds. And so it was really the diversity that saved many lives and kind of took the car industry forward. And then the last is actually Dr. Zuckerman. He says it compels us to learn about the lives, experiences essentially by others. Unless you can learn or see through the eyes of someone else, you don't know what they're going through and you won't be able to relate with them. So I just think that's a good starting point for orthopedics. So we're going to kind of first start off with making a case for diversity. We always say we are the best and the brightest. And as orthopedic surgeons, honestly, we are the best and the brightest. We don't treat we don't treat chest pain because we don't have to. It's not like because we don't know how to. So in 2019, it marked the first time that 50% of the med school class is women. So if we're really recruiting the best and the brightest, then 50% of our orthopedic residents should be women. Otherwise, we're not the best and the brightest. We're only, the malest. And, so we really have to open our doors at looking at recruit. And it does lead to improved business. Patients with race and sex concordant doctors actually reported to participate in the decision making. And it's very important how we talked about yesterday to have patient and doctor group decision making. It's important to empower our patients. There's a positive correlation between cultural competency and the patient's perceived quality of the physician-patient relationship. And we all know disasters that happen either on purpose or not on purpose in the operating room. And if you have a poor relationship with your patient, you are more likely to get sued. A great relationship with your patient, you actually are less likely to get sued. So the patient-doctor relationship is particularly important for the physician. Improved patient satisfaction is also very important because everything is coming outcomes based. And so you don't want to have poor outcomes and poor kind of compliance because you have a poor relationship with your patient. And non-minority physicians benefit from the diversity of ideas. So if everyone looks like you and everyone's lived the same experience than you, then you're not going to learn new things, right? But you want people around you who do not look or do not have the same experience. And I laugh at my faculty. We do have a lot of type 1 and type 2 diversity. We have African Americans and Caucasians and Asians, but we also have type 2 diversity. I grew up, from a type A family in the city, New York, and one of my favorite faculty lived in a double wide behind a gas station in Florida. So we could not be farther apart, but we really learn from each other daily. Yep. Okay, the residents know I'm terrible at computers. Okay. And this is just going on that research persistently shows that ethnic minorities suffer worse outcomes. And so really you want to recruit increase minority and women so they can address or develop relationship with these patients. Patients of color treated by physicians with similar backgrounds have better background. So increased diversity of physicians shape the workforce that actually looks like the patients that we're treating. Hashtag except for Vermont. So I told Elise this story. I came up and I was so excited because like every third house had a Black Lives Matter sign. But then if you add my daughter in, there are like 3 Black people and she's not even full Black. So there are no Black people here, but still you want to increase diversity, but it's not just, underrepresented minority, it's women. And that's incredibly important. And so increased physician diversity may raise the awareness of the people we work with. So the question is, we know why diversity is important. It's important economically, it's important for patient safety, it's important for patient care. The question is, how do we get there as orthopedic surgeons? So there are definite strategies: pipeline, increasing the pipeline, mentorship or sponsorship, institutional support, and a conscious effort. So a pipeline opportunities provide for exposure, education, and mentoring to students, and offers the opportunity to participate in orthopedic clinic and research. I love the Perry Initiative. Lisa Latanza is chair at Yale. She's one of the founders of the Perry Initiative, where they actually do student outreach and they take women and they do hands-on introduction to orthopedic field. 300 women are exposed to a single day of workshops, and their workshops all around the US, and their match rate is actually exceptionally good. This is particularly important because when you see women teaching women, you realize that it's not just power tools and you can do other things. Like as a department chair, I was also room mom for 6 years because I have twins. One you do one, what you do for the other. And so I am very mom centric, but at the same time, I'm very orthopedic and department centric. And I think that's an important message to get out there, that you can have a fulfilled home life and still have a fulfilled work life. Admittedly, not sleep too much, but still. There's Nth Dimension, which is a great program, which was founded in 2004. And it's exposed students to the field early in medical school so they can really start grooming their CV so they can be strong applicants. They actually do incredibly well, and 70% of their applicants to orthopedics match. So they had a great year this year matching women. And then the second thing is mentoring. Mentoring across all fields encourages students to take the next step in their education. It's a key opportunity for us as leaders to direct women and minority applicants and make the field more attractive. And so you say, what is a mentor? A mentor can be defined as a person who helps you navigate your potential and reach your personal and professional goals. So these were really my mentor. They encourage your ideas, they provide constructive and useful criticism, they provide timely and clear feedback, and they challenge you to expand your abilities, but they also respect your uniqueness and contributions. Now, data has shown that mentoring during the early stages of career has been associated with higher career satisfaction, higher rate in promotion, and personal growth. And so the sees a greater effect. So early mentoring actually has a greater effect on your career than later mentoring. Now, I don't think you need to have one mentor, and you really need to collect mentors. So there is a faculty at Anderson, and he has the most amazing ability of collecting mentors, still staying connected and reaching out to them, and at the same time keeping himself kind of in the forefront of their brain so they can help him. And now he's going to be one of the VPs at Memorial Sloan Kettering, coming from being an assistant professor of plastic surgery at Anderson. And as a combination, one, clearly he's a genius, but two, it's the connections he made. So you can have a scientific mentor, you can have academic mentor, you have a personal mentor, you can have a lifestyle mentor. My OBGYN when I was in residency was my lifestyle mentor. And she said, get a housekeeper. You did not go to Harvard Medical School to clean the toilets, unless you like cleaning the toilets, but I recommend anyone who actually likes cleaning the toilets. And it was amazing because it freed me up to do what I wanted to do, whether it was like actually speak to my husband or read. Get rid of the things that you don't want to do. And that was one of the best pieces of advices I got. And so she clearly wasn't my main mentor, but she was kind of one of my cadre. So mentors are super great, but most studies show that women in senior ranks has been really unchanged for years, despite considerable amount of uptick in the mentoring. And the question is it completely mentoring? And our argument is no, it's also sponsoring. So you ask the question, what's the difference between having a mentor and having a sponsor? In short, mentors advise you and sponsors advocate for you. So as a mentor, I would say, oh yes, applying to the MSTS, Musculoskeletal Tumor Society, is, a good idea, get with your colleagues. And the sponsor would say, Val needs to be head of membership. And literally that was the difference between Henry and Dempsey. Henry was Dr. Mangan was a great mentor, But Dr. Stingfield really paved the way for opportunities by putting you out there. So they do overlap. They both advice, guide, make introductions, give feedback, but a sponsor uses their power for you and for good, right? So they leverage their reputation so that you can be in these positions and succeed. Now, women tend to be over mentored and under sponsored. But there's a direct relationship between lack of sponsorship, opportunities, and the absence of women in these positions. Men are 46% more likely than women to have a sponsor, but the statistical benefits of sponsorship are true. High performance assignments, promotion, and pay raises. Sorry. So there's a great article from Harvard Business Review talk about women get fewer game-changing leadership roles. So it's these big roles that really change your career. So if you're put in this position, you are more visible to your bosses or the C-suite or your colleagues. You have a mission critical role. You have a larger budget. You have a large staff. You actually are a level of risk and show that you're a positive risk for your department, institution, company, and you have access to mission critical roles. And those are the things that people look for you to get to the next step. So if you're not put in this position, it is harder to get to the next step. And this is one of my favorite slides. This is actually from the New York Times. And it's a simulation of promotion over the years in women's performance. And you see, without this sponsorship and the mentorship, when you get to the top, there really, which is level 18, there are really there are no women there because over time they just kind of get factored out. So what can we do? We see what we can do as individuals, whether it's mentorship or sponsorship. And I think we all can be a mentor and we all can sponsor someone who may be junior to us. But the other is institutional support, continuing education for leaders. So high quality, in-depth anti-racist and feminist training, such as those offered by the Racial Equity Institute, rather than the short kind of programs that we all have to do in the computer that we dread and we get our secretaries to do, but actually true in-depth training. And then the leader allyship, which I'm going to talk about in the next thing. And then structural support. So for our faculty or our residents, time, funding, and expectations, this can be really important. So if you are head of diversity for your department, it shouldn't be something that you do in addition to everything else you do. That should be what you do. That should be rewarded. You, as a faculty member, should get money for diversity because you're taking time either for operating or for writing. I always say if an institution really values something, they're going to put money behind it. And then actually there's funding for support for junior faculty, for underrepresented minorities and women specific for local and national funding opportunities, and your institution should bring those forward. The AANC actually does great things with leadership and training for women and underrepresented minorities, and that's something as a group to look into. And then the last is kind of conscious effort. Program directors are uniquely in the position to increase the diversity in their residency. Applicant decisions should be made by strict, transparent criteria. And no, we used to have, oh, they're not a good fit, which secretly in orthopedics means that they're not white males, because they used to say, who do you want to be operating with at 2 o'clock in the morning? If you're a great surgeon, it shouldn't matter who you're operating with at 2 o'clock in the morning. So it should be who helps you the most in the operating room, who has the skill to actually benefit the patient. So I think that's one of the things we're really trying to push away from and kind of successfully in orthopedics. And then we have to be wary of our unconscious bias. We all have unconscious biases. Though I have a joke, I was on a call on an academy call and he goes, you have unconscious bias. I said, no, I don't. I have conscious biases. So I'm deliberately racist. I'm not, secretly racist, but he didn't get the joke. But in any case, you have to be aware of your unconscious biases. Hopkins actually chose to diversify its program without quotas at departments, but just actually trying to be more aware of it. And women increased from 4% from 20%, and African American increased from 0 to 30%. In Texas, we have the Rooney Rule, which actually we have our version of the Rooney Rule. The Rooney Rule is a rule in football where you had to have minority candidates when they're looking for kind of, coaching or administrative jobs at University of Texas, which I'm sure DeSantis is going to strike down solely because he's the devil. But you have to bring, when you're having a candidate forward, you have to bring women and underrepresented minorities in your pool. And so actually that's a picture of the last year's graduating class from University of Texas at Southwestern, where they were 50% women through this conscious effort. True diversity attracts diversity. Being 50 and still being the one and only in many situations is the worst. Like, it may have been novel when I was 12, but at 50, you want to see other people. I get so excited when I saw your women resident yesterday. It was great. Diversity attracts diversity. So that's University of Utah in the upper right-hand corner, and then USC Orthopaedics in below. So once you have, and we talked about that when we were talking about rotation plasty, you have 5 rotation plasties, you can convince anyone to have a rotation plasty. You have no women. Why would you want to be the only woman? Sorry, I was often the only woman. But why would you want to be the only woman? Why wouldn't you go where they have a lot of women? So you don't have as many of the issues on top of the kind of, challenge you have an orthopedic resident. So are we done? We're working to increase our pipeline. We have institutional support. We have a conscious effort. I would say we're actually not done. So there was an article, and the World Economic Forum report says it will take us 132 years to achieve gender parity in the US. I think in orthopedics, that number is twice as much, but it's clearly not going to be next door. And so what do we start needing? What do we need to start doing? So we are getting more women in positions of leadership. But once they're in the positions of leadership, it's our duty to continue to support these women. There was a JAMA article that showed that female physicians and underrepresented minority are essentially written up more than their white male colleagues. So you may think this is little, but as a junior faculty, when you're working really hard and your behavior, which is professional, is the same behavior as your colleagues, and you're getting written up, it does take a toll on your soul as well as hamper your advancement. So this paper suggests that there's a lower threshold for reporting women and underrepresented minorities for these kind of SI reports. There's a New York Times article by Rosalind Chow that says, not only sponsor, promote your women leaders, you really need to support them. And so once you get into the position of power, you have to avoid putting women in the kind of Goldilocks dilemma, which is they're either over analytical and unemotional or too emotional. And I always say, if you think I'm too emotional, just wait, and I can always be more emotional. But the fact of the matter is, you shouldn't be one or the other. And men don't get that problem. And so they're trying to, kind of work out the Goldilocks issue. I just threw in this slide because we all talk about DEI, and we always say, I feel like sometimes I talk and, it sounds easy. I think people who realize that it actually is hard. It's hard for people in position and power because it's really a challenge to their power, and they realize they're going to lose it. It's uncomfortable, and no one likes to be uncomfortable. And, it's the fear of actually saying and doing the wrong thing. So I definitely have colleagues who have great hearts, but they are very scared of being perceived in a ill manner. So there's a significant fear about saying and doing the wrong thing or the impact on their career. And for the marginalized people, being the lone voice is often painful and lonely. Being conspicuous is difficult. For a long time, I was the only women chair in at Anderson in the surgery. And it's not like they didn't know who I was, right? Because I was the only woman and Black. So there was no blending. So being conspicuous, being perceived as the token, and addressing the bias. So from both sides, from both kind of the leadership side and the marginalized sides, there is an element of fear. And I don't think that's one we can dismiss. But we do have to work once we put women and leaders, once we put women and URIs in these leadership position, to be aware that the tightrope or the double blind, in other words, what else are they dealing with in addition to their leadership, and how can it inhibit their advancement? So female leaders have more limited range of behaviors that are deemed acceptable. You can't be over emotional. You can't be unemotional. You must be warm and competent. And I was laughing yesterday because Elise and I were talking about one of my residents who broke up with his girlfriend. I don't care. But you can't say you don't care, or I shouldn't have said that I didn't care, because then I don't come across as warm and competent. But I shouldn't have to be warm. What I should have to be is an excellent surgeon who takes great care of patients and teaches. But women do have that extra layer that's layered on top of them. And they're also, if you look at evaluation, there's much more commentary on their interpersonal skills than their actual performance. And so that I mean, yes, professional is incredibly important, but that should not be kind of the gist of someone's evaluation. It should be, how they perform. And interesting enough, as I'm sitting here talking as a woman and a URM, women in URMs are more likely or more concerned with diversity, equity, and inclusion, but that actually causes them to be rated lowership in leadership qualities than for men. And actually for men doing the same thing, which is interesting. And then that brings up the question of legacy and longevity. Initially, it was very hard, especially in orthopedics, for women to be inclusive of other women because they didn't want to be seen as always carrying the banner. I do think that's totally changing where women are much more propping up other women, but I do think that was a hurdle to get over. And then also there's the Black tax. You have one faculty who's African American, and then you make him or her head of diversity, but she still or he still has to jump the hoops of being, prolific academically, a great surgeon, meet his budget, et cetera, et cetera. So we can't have people do it without giving them the time and the money or recognition. So the big thing is when you have underrepresented minorities or women in these positions is defending them, which is risky because once again, you're leveraging your self for someone else. But as a sponsor, you really work to conform, create, or challenge the perception of your protege, of your sponsoree. And this is either by talking about them and kind of changing or confirming that they're great, or once again, putting them in positions where they can succeed. So as someone who's defending someone else, you're leveraging their power and kind of pushing that person up. And that is allyship. And so this is the last thing I'm going to talk about. So allyship really is a lifelong process of building and supporting or nurturing relationships between women and underrepresented minorities or the marginalized groups for the aim of inclusion. And you can't have diversity without inclusion. So I think inclusion is incredibly important. Inclusion is progress, it's not perfection. It's an active, not passive process. It's frequent and consistent behaviors, and it's lifting others up. And it can be small things like when you come in and say, "Oh, Elise, how was the Rangers game?" When she knows she likes Rangers hockey, as opposed to just talking to the males about the Rangers game. And so that happened to me last week. We were in a group of chairs. One of my friends whose chair sat down and started talking to the neurosurgery fellow right in front of him about the Knicks. I'm from New York and I've been a Knicks fan forever. But literally, he zoomed in on the man. Are you kidding me? So, I mean, these things continue to happen, whether they're small and big, but inclusion is incredibly important. So, how do we move that pendulum? Day to day activities, not strategies necessarily, but just how you behave, having coffee at the water cooler. Great article, Harvard Business Review, about 7 ways to practice mentorship. Be curious so you can talk, you can have conversations, honest introspection, really look into yourself, humble acknowledgement. It's okay not to know and ask those questions, and empathetic engagement, right tone, something I've worked on all my life because my kids are like, "Tone, mom." Or I'll talk to them and I'll say, "Don't listen to my words, listen to my tone." So when you're talking about diversity, it is a lot of tone because you want to create that safe space, authentic conversations, vulnerable interactions, whether you're being vulnerable or the person you're speaking with being vulnerable, and then being courageous. I mean, we are the best because we're orthopedics, and we have to be courageous in every facet of what we do. So that's what leader allyship is. You want to acknowledge and report acts of implicit and bias. So you're supporting your residents, your fellows, your attendings, and clearly articulate a commitment and articulate it with money and a budget. So diversity, inclusion, and equity require support on every level: school deans, center directors, department chairs, division chiefs. It's support in the form of vocal, written, and financial support. So honestly, by failing to act to address the issue, we require the disadvantaged to overcome their own hurdles. So what you're saying is, I'm going to cut off your leg. I tell you need to run up the steps without giving you any help. We definitely can't do that. Taking these actions will allow underrepresented minorities and women to succeed in ways they can create diversification for orthopedics and help everyone in concern. This is one of my favorite slides. It's equity, equality, and justice. So inequality, we all read The Giving Tree, right? Growing up, that was pathetic. How do you put that in? But in any case, the tree's bent over. One little kid's catching an apple, the other child's not. And then equity is they're both picking apples, one has a taller tree so she can get to the apples. And then equality is both giving them the same ladder. So yes, they have the same right thing, but we haven't hit the problem. And then justice is actually correcting the tree. So the tree's standing up straight, and then they both have the same opportunity. So what we're looking for in orthopedics is equity and justice. So in summary, African American, Hispanics, Native American, and female surgeons are woefully underrepresented in surgery, and especially in orthopedics. And improving diversity will improve patient care, improve our profession, and lay the foundation to address the persistent disparities in the healthcare. So this turned out to be my actual road compared to the ones we started off with. This is my true north. I have two twins. I guess you can't have three twins, who are women who are interested in medicine. Olivia spent the summer with me in the OR last year, which was amazing. And thank you very much. Any questions? Oh, is someone raising their hand? Oh, no, it's a great question because I feel like I don't juggle it well, right? Because, as the only Black chair, we go division department. So we have a division. He's like the head of division of surgery, and all the departments are. So my division head, who has come a long way in the last 15 years, kind of put me the head of DEI. And I was like, okay, but I also have a faculty department to run and a lab. And I'm actually still a very busy clinician. What are we doing to support this? So I did push back on it because I thought it should be something twofold, something that we kind of do as a division, but also maybe you should be head of DEI because then you would learn things and then you could talk to your partners, but then you kind of trick them into realizing why it's an important thing. So I did that, and it actually went to two white male chairs, neurosurgery and head and neck, and they did a horrible job. So then I actually ended up having to take over again and helping. So yes, you want to diversify the effort, but you can't completely step back because you do want to steer the effort through. And I think at Anderson, one of the big DEI thing is in my department, we have, its own, three African Americans, Hispanic, Asian. I mean, that's the best form of kind of promoting diversity without, a strategy or course or anything like that, is kind of making your department look like the patients we treat, right? Because in Houston, it's third white, third Hispanic, third African. But it's funny because I was, not that I didn't do this talk months ago and was totally prepared when I came versus finishing on the airplane yesterday, but the person sitting next to me and said, "Oh my God, are you the DEI representative of your institution?" I said, "Oh, absolutely not." And she goes, "Well, I was just put on this committee," and she's struggling with that same thing, And I also, at the beginning, felt like I don't, me talking about DEI, I don't want it to seem like I'm whining, right? And it is perceived. The data shows when women talk about women being underrepresented and needing more women, they're initially perceived as whining. But when a man talks about needing more women, they're enlightened and bringing the specialty forward. So when I originally was doing it, I didn't want to seem like I was a whiner. And I hate whiners. So
Clearly, you're passionate.
Yeah, I mean, I think that's a combination of, being a New Yorker, and my parents where I kind of think things and it kind of comes out of your mouth at the same time. But I do think it's important for really being honest and having an honest conversation. I do use kind of levity to make people feel a little bit more less uncomfortable because if you come at someone, they're immediately going to get defensive, even if what they said is egregious. But if you can kind of come to the conversation a little bit more kind of circumspect, then whether they realize it or they're a little bit more comfortable. We were on a search committee for the new head of medical oncology, sarcoma medical oncology, and I kind of wasn't really paying attention. And they were talking about candidates, and they were like, "We're looking for anybody. We're looking for, we'll even look at associate professors. We'll look at international candidates." And I'm like, "We'll even look at women." And so I was like, "Oh my," I said, "let's not go crazy." I said, "Let's not just go all the way out on the left field." And then they realized as I'm making fun of them and smiling, what they said was absolutely ridiculous. And so I think if you can make people hear what they say, unless they're truly racist, um, they are going to realize what they're saying, and they're like, they'll be like, "Oh, maybe that doesn't sound as good, or maybe that was, inappropriate." And if someone says something to you, you can ask them to repeat themselves. And if if it's unconsciously inappropriate when they repeat themselves, they'll realize how horrible it seems. And then even if they meant to say it, they'll actually realize that you realize that it's horrible, and it will take them back. And so I do think you should always be honest. And I am very honest with people. And I do kind of use a little bit of a levity to keep them more comfortable when I'm bringing my point forward. Because also as a New Yorker, I will be quickly get in your face. And so that, I live in Texas. Ugh, and so that's the issue because everyone's very slow and soft, and I'm neither soft nor slow. So it is something I consciously have to kind of remember and think of. But I think putting kind of a little levity in it makes people a little bit more comfortable. Yeah, because there are no black women. So I can't, that's one. And then yeah, go ahead. Yeah. Which situation? So I do think maintaining mentors is an active. So I say to residents, when you have a mentor, you have to reach that balance of not reaching out to once. I had a medical student who emailed me every day, every week, literally every week. I don't want to hear from you and I hate you by that point. But you want to keep yourself present in the person's eyes. It was my student last summer. And so I hear from him like once a quarter with a small update of something he's doing, really so that he stays in the forefront. So now if I'm looking at for a medical student or thinking about a resident, he's still in my mood. So when you have your mentors, it's not just them giving to you, but it's you reaching out to them. And whether it's a mentorship, I actually do a talk for junior faculty. You should always have a 30-minute elevator speech. So when you see Dr. Ames and she says, "How are you?" do not end up with "fine." What you want to say is, "I'm great. I did a great case and we did this," or "I'm great and I just finished this article," or "Great, I'm looking for this grant," so that the person above you or your mentor knows that you're working and you're going forward, right? Because we do end up mentoring a lot of people, but we'll sponsor the superstars, right? Because you're leveraging, your reputation and you want that person to be a superstar. So I do kind of consistently reach out to my mentors to let them know what I'm doing, as well as asking for advice and things. And small things, remembering their birthdays. I mean, that little personal touch, no, but that little personal touch is important as well. And then aside from mentors and sponsors, I think my dad ended every conversation until he died at 85 with study hard and get good grades. It all comes down to working, doing well, and being the best you can be. Sure. Um, no, that's fine. I'm spoiled because I think my faculty are all somewhat like-minded in that way. So I think if they think they're whiners, honestly, I'll think they're whiners. And I do think they are more sensitive to coming to me about complaining about a woman or underrepresented minority, right? So I do think just being their boss kind of causes them to have a mind reset, right? Um, but also we actually look at the faculty and instead of saying they're not doing well, why don't we help them? And maybe they should have more lectures. I like didactics. Maybe they should have didactics, especially in oncology, because everyone comes in knowing nothing. So we kind of will take that tactic of kind of supporting them, maybe with additional didactics or reading, or maybe they need more time on your service so they truly can learn, the issues that you feel that they're not doing well. And then I'll actually talk to the resident myself, especially if it's a woman. And that's one of the things, sorry, when you're talking about, so you talk about leadership. One of the things about leaders, it's hard if you really want to do diversity, but if your faculty totally don't want to do diversity, it's hard making that step. And that it's also fear, right, of losing control of your faculty if you're taking them down a completely new path. And sometimes diversity is that new path. And I can think of one chair where his faculty are totally not wanting to come down that path with him. And he's really bringing them down. And then you have to question it's very important, but how important do you think it is? Because clearly, as their department chair, you also control their finances. So if it's they're not, we call that kind of their not companionship, but their becoming aphasic, kind of, their group attitude, and that's part of their pay. And if they're not doing, that part of it, you can, maybe cut back on that. I mean, I think it's persuasion, but it also comes down to money. I think once you get a foothold in, then it will increase. Um, universe your program, right? So you have one African American and one woman. So this is the great time for your interviewees to see an African American and woman be successful. So the key thing is not just having women, but seeing women in the program who are successful and who are happy. You don't want to have a program where they're like, don't come, because you're not going to get any women. So if you have a program where the women are successful and happy, you will definitely get other women. I mean, there's a core article where women go to Northeast programs and Pacific Northwest programs. And they don't go to the Southern programs, obviously, except like Duke and things like that, because you're the first and the only. And orthopedic residency is hard. And then to have like people who aren't supporting you, it makes it even harder. Or even not supporting you, who are deliberately not supporting you, makes it harder. So this is a perfect opportunity for you guys to get more women because you have a successful woman and a successful African American. Your next class is going to be 50% women. I feel it. What? Oh, okay. You'll have in one woman. I'm going for 31 women in next year's class. Oh, he's just drinking. All righty. Thank you so much.